Welcome to today's webinar, Telehealth in Indian Communities, Reaping the Benefits and Overcoming the Challenges, brought to you by Tribal Edge Insurance. You can ask a question at any time during the webinar today by typing in the chat window on the GoToWebinar toolbar on the right side of your screen. All questions will be addressed at the end of today's webinar, time permitting. During the webinar, some of our presenters may ask for interactive questions. You can answer these questions by clicking again on your chat or question windows. A PDF of the slide and a link to today's recording will be sent after the webinar to registered attendees. I will now turn it over to our first speaker today, Chairman Marshall Pierite of the Tunica-Biloxi tribe. Marshall?
Good afternoon, everyone. First, I want to give all honor, all praise, and all the glory to God the Father, the Son, and the Holy Spirit. I pray that all is well with thee. My name is Marshall Pierite. I am the chairman of the Tunica-Biloxi tribe of Louisiana. And before I begin, I want to give a huge shout out to my fellow panelists and to Tribal Edge for putting on this webinar in order for us to educate and advocate and to provide awareness to the resources that is available to Indian country as well as rural America. My father had a saying that the pain of change is difficult, and also the pain of remaining the same is extremely difficult. Change usually begins when you bring awareness to what needs to be changed. Change comes to boiling down to making a decision whether to stay the same or bring change to your community. It's about providing discipline or having regrets on the long term. It's about choosing between blessings as well as burdens. The burdens that is upon us with change is more associated with human nature. People do not like change because usually they focus on what they're going to lose instead of focusing on what you are going to gain. And I want to share a little story about Tunica-Biloxi and talk about the blessings that is associated with change, good, positive change. When it comes to your broadband capacity as well as the telehealth capacity, which Tunica-Biloxi is presently doing, it's like giving a master key to every tribal citizen household. A master key to unlock doors of opportunities to transition from maintaining their health to improving their health to enhancing their lifestyle. Health in its own unique way is like faith. It is measured by by your progress that you make. And if there's no movement, then is no improvement. And with that master key to healthy transition, you can control your own destiny by creating a more robust and holistic approach to your lifestyle or to your health. A more holistic approach, you go from treating a symptom to addressing the root of your problems. And by addressing the root of your problems, you can get to the truth of your problems. So, I want to make all the tribal leaders aware, and again, applaud Tribal Edge for putting this webinar on, because what it does, it allows Indian country to create a platform where we can quit treating illness in our community and build wellness within in our communities by increasing our capacity. As a civil rights leader once said, only when you replace an I with a we, only and then only illness can become wellness. And again, a huge shout out to my fellow panelists and to Tribal Edge for putting this webinar on. And grace, mercy, and peace be with all of you. And may God continue to bless each one of you. And may God continue to bless every nation that is represented here today. And now I want to turn it over to Mr. Ted McKenzie for a TED Talk. Thank you, Ted. Thank you, everyone.
Well, thank you, Chairman Marshall. That was fantastic. I wanted to introduce myself. My name's, again, Ted McKenzie. I am the administrator of Tribal Edge Insurance. Tribal Edge is a native-owned insurance and benefit brokerage firm. And I have the pleasure to work very closely with a dozen or so Native Americans that represent tribes throughout the country. I think it's what's important about that is when you look at the health disparities in Indian country, our team is represented throughout the country. So not only do I see it from the discussions I've had with them, I've seen it through their contacts, their tribes, their friends, and it's eye-opening. COVID-19 is a great example of disparity. One of our tribal members, his tribe was devastated by the COVID-19 virus, and yet we've had others that haven't had as much impact in their communities. I know that you're all familiar with alcoholism, type 2 diabetes, and heart disease being prevalent in Indian country. Mental illness and suicides are becoming very significant, and we need innovation and technology that's gonna arm our fellow Indian country members to address the healthcare issues around all of these health disparities. The other thing that they face are these challenges with things like geographic locations. Indian country is spread out on some of the most beautiful but isolated and underserved parts of our country, which is really significant when you need consultations or you have an emergency or you have you need specialists. So how do you address healthcare when you live in a place that you can't get to a healthcare facility quickly? Transportation's an issue. It's not only time, it's cost, and it's distance. There are fears of providers. You know, people don't like going to the doctor or seeing a doctor. If they have mental illness, it's something that they tend to avoid. So all these challenges are something that we need a significant increase in network providers and specialists, and we have to find ways to overcome this. So telehealth is one of those ways, right? It eliminates the distance, it eliminates the issues with travel. I know there are challenges with telehealth that Joe's going to address, but it really does overcome many of these things. It overcomes the fear of being able to talk to somebody. You're able to have the consultations. If you have a mental illness, you don't worry so much about going to see a doctor. Now you can actually call somebody, text somebody, or FaceTime somebody. So it's easier, it's faster to see people that you need to see. And I think that as I turn it over to Greg Grant, the COO of Medici, you'll really be able to hear why telehealth is transforming healthcare in Indian country today.
Ted, real honor to be presenting today for Medici, and love the heart of Ted and the organization to really try and make impactful changes that will change people's lives in the Indian country. I've got a lot to cover and I'm going to jump in right away, but today we want to tell you about a next generation healthcare system that we believe is perfect in some ways. for the needs of the Indian country. And we're going to talk about it. Some of this is going to be quite revolutionary, and some of it is super innovative, but we've seen incredible results with our model. And in essence, Medici enables employees to offer their own virtual first multi-specialty health system that is underpinned with remarkable doctors and super efficient technology. We integrate primary care, specialty care, behavioral care with labs and imaging and urgent care, all from one phone text number, and no app required. Medici is really effortless, and we're going to dive into that a little bit more. So if we can go to the next slide, we talk about it as our Series 7, but in essence, a tribe or a community in the Indian country will have a single phone number that they can text in, which gives them access to the little helicopter, which we call our care concierge team, or our group of healthcare navigators. And what these people are trained to do is to lovingly navigate your care that you might need as a patient. And whether it goes for cardiology or musculoskeletal, behavioral or lifestyle and diabetes care, it's centered around a primary care physician who is there to have a long-term relationship with the Indian country community member to make sure that their healthcare outcomes are improved. And the primary care doctor, and Dr. Allen, who speaks later, will go into this, is surrounded by remarkable specialists that can provide holistic care for the tribal member. Next slide. Underpinned by this is we have direct access to an organization called Second MD, which provides 850 of the world's best doctors, covering 130 subspecialties. And within 3 days, we can not only have the consult with the primary care doctor, but we could set up a second opinion consult. If you've had a sex specialist opinion provided, we can provide a second opinion through this partner that provides incredible insights to your condition and how it might be the best way to treat it. Next slide. This is just an example of the state of Texas, but it's important because a lot of people might feel, well, that's virtual medicine. What happens when I need to go get some blood drawn, or I need an X-ray or an MRI image? This is just a very quick snapshot of how we have got an interconnected system with our care concierge, who you text in, that can access for you and book appointments for you at a lab or an imaging place that's the closest proximity to where you might live. Next slide. So we want to give a quick comparison here. In some ways, we think ourselves as the Mayo Clinic of the future, but there's some fundamental differences. So like Mayo Clinic, they've got exceptional doctors, they had a team approach, they have a strong mission. That is all true for Medici, but unlike Mayo, we've got some distinct differences. Our infrastructure is very different, and we'll go into that now. Our primary care is the focus of what we do, and the ease is where we pride ourselves to make sure that it's easy and available with easy access for people that need care. Next slide. Touching on the infrastructure, so unlike Mayo, we don't own buildings, but we've built a world-class AI, or artificial intelligence enabled virtual care platform. And what I mean by that is we can provide a text link to a member, and they can do a facial scan, and it gives our doctors very key insights about their blood pressure, their cardiovascular risk, their stroke risk, their skin age, their body mass index, and great pieces of information that we can help monitor patients remotely, and also give the providers information real time about the patient that they are seeing. We don't buy diagnostic equipment like Mayo and large hospitals. We have an integrated, connected network that we use to get very cost-effective imaging done. And instead of hiring, a few doctors, Medici's got, the best specialists in the world. We've got a group of specialists for Medici that would care for the Indian community. But in the instance where that really requires an advanced subspecialty, we have the underpinning of Second MD. Next slide. At the core of our care, as I mentioned, is primary care. Dr. Allen will go into why this is really important. But these doctors are hand-selected and trained They are focused on one, in our examples, on one employer, but it could be for one large Indian community. They interact with each other, and the specialists, they are very proactive in their care, and they're mission-based. They're deeply empathetic. A lot of our doctors are, focused on global health. They go out into impoverished communities as part of how they are wired. They're very unique in that they really care deeply for their patients. But yeah, we don't trade off quality of care and time with patient with being slow. We pride ourselves using great technology to be able to get a response from a navigator within a minute, to be able to set up with the primary care doctor in under 24 hours and oftentimes within the same day, specialty care within 48 hours, and then subspecialists within 3 days, as we mentioned before. But you get real care from real people. So the thing that's remarkable, sometimes people feel like, well, I've texted somebody, are those real people? Yes, these are real people. This is just one team that serves one of our clients, and you can see these are the faces and the people that are behind the virtual interactions. Now, the patient will text him, but if they need a virtual video consult, these are the providers that would get on the phone with the patient and help them, whether it's for nutritional needs like a diet, all the way through to cardiology if they've got heart issues, and we also provide veterinary advice should you have a pet that's got an issues, which you might be able to save hundreds of dollars to try and find a veterinarian. Next slide. And it's easy. So, Ted mentioned this before, and I know that in speaking to some of the other panelists, traveling to find a care facility is oftentimes very difficult. And so we eradicate that by being able to do that from the ease of your home. And with all the initiatives and focus that a lot of the Indian community leaders are doing to get broadband to their communities, we'll piggyback on the back of that to be able to provide access very easily for Indian communities in the Indian country. And instead of leaving your primary care physician, which happens a lot today, to go see a specialist and the two never speak, you will have a whole team of doctors and specialists that come around you and look after your health for the long term. And then lastly, but very importantly, we are very angry about the complex billing that often accompanies healthcare. And we've made this incredibly simple so that any pricing is immediately available and transparent to the leaders of the community as well as to the patients before they get care. Next slide. So the way that we like to think about this, if you take it away anything, we've got incredible doctors. They are surrounded by remarkable technology that is world-class. With a single text, you can get access to a team of people that would be loving and very equipped to care for your healthcare needs. And we've got tremendous pricing that's enormously cost-effective. Next slide. But we handle a lot of healthcare services. So some use cases are your yearly physicals or health screenings, obviously acute care for if you've got something that's wrong and you need something addressed right away, general health questions, prescriptions, labs and imaging, diet and nutrition, and the list goes on. Most, let's say above 80% of medical encounters can be done virtually. It's just that people think that they have to go into a clinic, and that is not always the case. So why Medici? At the center, primary care supported by swift, efficient, helpful, loving concierges who navigate the care for you. No or very low cost for the individual. Fully connected specialty around the primary care. Incredible navigation. After hours care, so at the middle of the night, if you wake up and you need help, there's an emergency nurse team and emergency doctor that can determine should you go to a hospital or an emergency room right now, or can it wait until the morning? No travel time, same day consults, and we handle prescriptions as well. So a lot of people say, so you guys are like Teledoc, and we use Teledoc as an example because it's the most synonymous with telemedicine. But there's some fundamental differences which are really important, because Teledoc always has different doctors. You never speak to the same doctor. You get one-off visits. You're on your own. There's no navigation. The doctor knows nothing about you, and they're disconnected from specialists. Whereas with Medici, it's always your doctor. The doctor that you get, your primary care doctor, remains your doctor. It's fully integrated healthcare. There's full concierge support to hold your hand every step of the way, from strep throat all the way to surgery. Medici will know you. They'll deeply know you. They'll understand you. They'll know the dynamics of your family, the social determinants that are impacting your life, and it's fully interconnected with specialists. Next slide. We see ourselves in many ways disruptive to the major hospitals today, and some of the flaws with the major hospital systems today is that they are surgery and revenue focused. They profit from people being sick. They've got enormous cost structures that they have to find ways to charge patients to cost. Their costs are concealed, so you always get surprise bills and you never really know what you're going to pay. There's a lot of fragmented care, and it's very difficult to navigate. And all the reasons why we created Medici, we're health and outcome focused. We profit from your health and your well-being. So we set performance goals and outcomes with the leaders of the Indian communities to say, if we don't achieve those goals, you will not get charged from Medici. We've got a lean cost structure. Costs are very clear and transparent. We've got incredible interconnected care, and it's effortless to navigate via the text and through our concierge team. Next slide. I'm going to hand over now to Dr. Kobe Allen. He's our Chief Medical Officer, and he's going to dive a little bit deeper into the medical reasoning, justification, and evidence that supports why this model is so effective.
Thanks, Greg, and welcome everybody. Yes, as you can see from the slide, I'm kind of an interesting doctor. I'm actually a primary care doctor, but I would say at the extreme end of the spectrum in terms of specialties. I work in both emergency medicine and infectious diseases, and so I really have a pretty good understanding of just how bad the American healthcare system is. And I can tell you that without a doubt, it's worse for Native American populations in America. I've actually lived on Navajo Nation. I've seen the care. I know people are trying, but the reality is the outcomes are simply unimaginable. What's happening to our Native American populations in terms of their health is now rivaling some of the poorest countries in the world in terms of lifespan. And I'll show you some of the statistics about that in a second. So when we talk about lifespan, this is a study that just came out. It did not include Native Americans, but it looked at American lifespan versus lifespans of the next 17 peer countries, meaning social economically well-to-do countries like America. And what we found is America's not doing well. 76 years in 2021, and it's dropped several years in age since the beginning of the pandemic. And whites have held up pretty good. Blacks predominantly had the largest drop in lifespan. And when you look and drill things down, we're about 5 years shorter lifespan compared to our peers around the world that have similar social economic systems. Next slide. So unfortunately, and I'd love for people in the audience to try and guess, but the reality is the lifespan of Native Americans in America now after COVID has dropped way more than anyone else in the world has reported so far. So we went from 72 years to 67 years, and now we're down to 65 years. So right now, as mentioned earlier, we see lifespans among Native American populations that rival the poorest countries in the world that are spending nothing, like a tenth or less per capita on healthcare than we are. What is going on there? What's driving this? I want to get a little bit more into that just so we can understand why Medici is designed like we are. Next slide. So in terms of things that are really driving our overall lifespan, it's clearly a chronic disease issue. And in America, we're very unhealthy, frankly. We have 60% of adults right now that have at least one chronic disease. So the rule is you have at least one, but almost half have two or more. And what's crazy is it's driven a lot by diabetes and prediabetes, and clearly the highest numbers for diabetes and prediabetes in America are among the Native American populations. It's 2x the white population in America right now. What's crazy within that is 1/4 of people right now walking around with diabetes have no idea they have it. And this really gets at the lack of preventative nature of primary care in America, the fact that we just don't care about prevention in America. And why that's so important is because primary care's main role, the reason we exist is to care about prevention. and really helping people understand the ramifications of the way they live their lives. So that's a crazy number. Fourth of people don't know it, but when you look at pre-diabetes, which within 5 years, most pre-diabetics are diabetic, you're talking about 90% of people don't know it. And it's now almost 100 million Americans that have diabetes or pre-diabetes. And that's, that's the main driver of a lot of the health problems we have. But with pre-diabetes and diabetes come along all these other things that the World Health Organization and the CDC are saying are driving mortality around the world and increased costs. And you see that the CDC estimates that of these different factors shown, heart disease, cancer, chronic lung disease, stroke, Alzheimer's, diabetes, and chronic kidney disease, that almost all of that is driven by lifestyle. And I'll talk a little bit more about that, the percentages, but it's a huge chunk of what we're spending. And then the devaluing of primary care in America is striking. And this is frankly why I now work for Medici and I've left academic medicine, is because I lived in the broken system. And I didn't want to be a part of it anymore. And what's so broken is we just don't care. I mean, when it really comes down to it, we just don't care about primary care in America. We spend about 5 to 6% on primary care, meaning for every dollar spent in primary care, we spend about $15 in specialty care in America. That number should be closer to at least 15 to 20% in order to maximize outcomes. And that's been proven over and over again in different states in America, as well as different countries around the world, that the more you spend on primary care, good primary care that cares about prevention, the less you spend and the healthier your population is. Right now in America, we spend way more than anyone else in the world, and we have half the outcomes, twice as bad of outcomes, twice as much money spent. It's crazy. Next slide. So let's talk a little bit about primary care through telemedicine, because a lot of times there's still that concern, is this legitimate medicine? And the answer is yes, it absolutely is. And not only is it legitimate, it's actually been proven to improve access, decrease costs, and improve outcomes. So those are all, that's like the holy trinity of value. All those things have been proven in primary care. And then there's really good data that says the states that spend the most on primary care have the least overall expenses in healthcare. Next slide. So the other thing that's really shocking is it's the incredible exception that anyone is actually up to date on their preventative care in America. You see the number is 8% of adults over 35 right now are up to date on, these aren't like questionable, I don't know if I really need that. These are like proven, improved outcomes if you have these preventative services done. So meaning 92%, and those numbers are lower clearly for Native American populations. The other thing that's really telling is that's just the devaluing of primary care by patients. Patients have started to try and navigate their own health by going straight to specialists. And there's this interesting phenomenon where specialists now are taking over primary care and doing a terrible job with it. And they're the part of the fragmented system, the over ordering a test. Nobody's communicating together. So we need to get people plugged into primary care. It's been proven to lead to better outcomes, decreased costs. So we're part of that. So what else is really, really shocking is America has decided that their health, individual health, is not their problem. And I can speak to this because this is me. I was absolutely one of those people that felt like my doctor's job is to get me healthy. When in reality, this is a team sport. We need doctors and nurses and care concierges and patients working together on health. Right now, less than 3% of Americans are considered healthy, as defined by not smoking, eating a healthy diet, exercising appropriately, and not overweight. That's a shocking number. And that's why we spend twice as much on healthcare and have by far the worst outcomes of the top 12 countries, and I'd say top 20 countries in the world. Next slide. So how do we address this? You have to think about the person as a whole person. And this is really where lifestyle medicine comes in. Lifestyle medicine is the idea that most of the problems we have in health right now are lifestyle decisions that people make that are unhealthy. And so how do you help people to start to address that is you need to have teams that are all on the same page, that are not shy about talking about lifestyle every single time we interact with a patient. This is Dr. Thangadoo. Dr. Thangadoo is a world famous endocrinologist that leads our lifestyle team. And what she's been able to show in this model of an integrated lifestyle team that works with your primary care doctor, there's always primary care at the center, is that we are able to get our average patient to lose about 10 pounds, to drop their hemoglobin A1Cs to where they're well controlled. And when you do that, you actually save a ton of money and you have all the other downstream benefit of improved health, loss of weight, better exercise regimens, all those sort of things. And we start to talk about not just disease management in this world of Medici, we talk about cure. And so we're not ashamed of the word cure. And when we talk about disease reversal and going into remission and no longer needing insulin, which is something we see all the time, we're curing people. And we're not just curing them for a year, we're curing them for life because they have done this through developing healthy lifestyle habits. Next slide. So I want to talk about two very different paths. This is absolutely what's happening in America right now. There's this really sketchy path on the left here that looks really dangerous. It was very expensive to build. You have no idea where you're going, and there's no room for anyone to help you down that path. And then you have this really nice, beautiful, broad path where you've got someone helping you walk down the path. So let's talk about the first one, status quo. So this is a real scenario that we see all the time. We talk about a 45-year-old mother of 3. She's overweight. She's stressed out. She's about 48 miles from the nearest clinic. This is a real situation. So she's, you know, in this current fee-for-service model, the current system, Indian Health, whatever it may be, she just doesn't really address her health care because she doesn't feel sick. As I mentioned, lifestyle medicine addresses a lot of diseases, but many of those diseases are silent killers, meaning you don't know you have them until it's often quite late. And so this patient waits now, 3 years later, she says, man, I finally feel bad. I'm gonna go into an ER. And this is a real reality of how people introduce themselves into the healthcare system. She goes in for dizziness. She sees this, wow, her blood pressure's up. I didn't even know I had high blood pressure. Hey, her glucose is high. They admit her to the hospital. They say she's got hypertension, probable diabetes. They want to do some further testing. Leads to a CT of the head, which probably was not needed. EKG that probably was, it was normal. The normal stress test, maybe didn't need that. Fasting glucose finds that, yeah, she's got a high glucose and her hemoglobin A1C is elevated, meaning she has diabetes. But unfortunately, she now has end organ damage. Her kidneys are starting to feel the effect of this. And this is where it gets really expensive, and a lifelong trajectory of unhealthy living will lead to this sort of organ damage that's sometimes irreversible. So she's discharged a couple of days later. She's now put on 3 medicines. She's referred to 3 specialists, no mention of primary care. She's diagnosed with hypertension, diabetes, and mild renal failure with obesity. She has 4 diseases now. Cost about $27,000, not what they charged you. You actually paid $27,500 into this. So 1 year later, she's seen 7 specialists, 2.5-hour drive or longer, often 4, 5, 6 hours. Some people are flying to their specialist now. Multiple medication changes. She's now on 4 instead of 3 medicines. She has poor control of her diabetes. It's actually gone up in her hemoglobin A1C. Her blood pressure is still poorly controlled. She has stable renal dysfunction, but still ongoing kidney disease. And she's only seen her primary care doctor 1 time for 10 minutes. And she frankly said, I had no value. And that's because primary care in the typical model and status quo has no time to do their job of coordinating your care and being the quarterback for your care and understanding everything about your care. So you fast forward 10 years from her initial entry into this scenario, and you see she's got end-stage renal disease. She's on dialysis, several $100,000 a year in costs. She had an amputation below her knee. She's had a heart attack. She's had a stroke. She's permanently disabled. And then unfortunately, her lifespan was only 61 years. This is a very realistic story. We see this story all the time. As an ER doctor, I see this population all the time thinking I'm their primary care doctor. That's not okay. Let's talk about the path of Medici. So in path number 2, we don't talk about disease modification. We talk about prevention and reversal. So we have the same woman, 3 kids, overweight, too far from a clinic. Well, she just received information from tribal leadership about this Medici thing and her single phone number. She said, what the heck? I'll just text them in. I don't feel bad. 9 seconds later, and that's about average for us, a care concierge will say, hey, this is Nicole. How can I help you? So Nicole quickly starts to onboard her. No clipboard, just a quick onboarding process to get her plugged in. And she sets up the first virtual appointment with a lifestyle-focused doctor, Dr. M, who's going to go through the things that really matter in this patient's health. She focuses on preventative and wellness things. She uses our camera-based app to get vital signs that are world-class, accurate vital signs. And she starts to address the lifestyle pillars. So what are those pillars? And they're things, it's just common sense, right? But this is why Americans are so unhealthy is diet, exercise, sleep, stress, substance abuse, and social support. All those things are what drive most illness in America. And it takes a medical team that's loving and surrounding a patient to really start to engage a patient to believe some of these things can be addressed. And it doesn't happen quickly. It doesn't happen with outsourced lifestyle apps. It happens with real, loving, trusting relationships. So what they see is, yeah, you've got some issues we picked up with our app. Your blood pressure truly is borderline high. Dr. M expresses some concern for prediabetes in this, and they plug you right back into our care concierge who does all the work for the patient to start to get testing and coordination of things and next steps. So 1 week later, this is probably a little longer than average. We are already getting lab results back, all the test results we want back, and we have a conversation, a 1-hour conversation with the patient about where they really are with these silent killers that are going to take them out way earlier if someone does not address them. And we find out, yes, you are pre-diabetic, not waiting 3 years for diabetes like the last scenario. The mammogram is up to date, colorectal screening is up to date, and there's no kidney damage, importantly, because we've caught you before you have organ damage. So what happens then is that the doctor will really deep dive with the patient and start to understand what is motivating a patient to change. And this doesn't happen always on the first try, but you start to see there are some things. I want to see my grandkids married. I want to be able to go on a walk and see the beautiful things around me, and start to say, well, let's do that. Let's take a walk. Let's just get you outside a little bit. And what happens then is when we start to say, yeah, you would benefit from some pattern change, some behavior change in your life. We have an intensive, we call it a boot camp internally, but it's our lifestyle medicine program. Well, we'll plug you into a team that includes your primary care doctor, but a lifestyle trained specialist, an endocrinologist, a nutritionist, a health coach, and importantly, a behavioral scientist. Because what's been shown is the main thing that's keeping somebody from really starting to initiate lifestyle change is not their health, it's the way they think about their health. And so there's nobody better than a behavioral scientist to help somebody take those first steps, to think about their thinking to the point where they can actually start to address those things. So you start to come up with a plan. And what's really interesting in our model is it's not a one plan fits all. It's very personalized, and we're going to do a lot of tweaks. And we're going to tell the patient up front, there's going to be 5, 10 different versions of a diet until we find something that sticks with you. We're going to try 20 different exercise programs until you find one you actually like and are enjoying. So it's this iterative process that really helps a patient feel like they got a part of control of the whole thing, and they're doing the things they actually enjoy. And this is exactly what happened with me. I've lost 25 pounds in the last year, just starting to be more practical and pragmatic about how I address some of my own health issues. So a week later in this patient's scenario, they begin our lifestyle program. They start taking these small steps with frequent adjustments and encouragement. And then next, 6 weeks later, the patient leaves that program. So they don't leave that program and that boot camp without tools. They have all these new habits they've started to establish, and they have an action plan. And importantly, that action plan is now taken over by the primary care, but we will have some of the components of our lifestyle program stick around, like our dietitian and so forth. Leads to a weight loss, it leads to blood pressure dropping, and hemoglobin A1C is no longer diabetes. It's pre-diabetes, so we got to have some continued work. So we're going to get this patient to a point where hopefully we can get them out of that category. And then you start to see this continued support really leads to, I would say, that whole trajectory change in someone's health, so that 3 years later, we're no ER visits, we're on no medications, we're normal weight for age. This is cure. This is disease reversal. This is what we see in our programs when we love on people, when we give them the resources and the tools and the equipment and the ease of access that exists in our model. So that at 55, this patient is not only healthier, they're much healthier. I'm much healthier now than I was 10 years ago. There's no chronic disease. And this patient's life expectancy went from 61 years to now 86 or longer based on the current projections for a healthy 45-year-old without any chronic disease. So that's it. I think that what we're doing is remarkable. It's really common sense. And it's doable because we have completely broken down how primary and specialty care works to do what the patient needs and not just what works or what we get paid for. And so I want to pass things on to Joe. Joe Valandra will be introducing himself and talking about how we make it easier for you to have the access you need to address your health.
Thank you, Doctor. That's a impressive presentation, even though I've seen parts of it before. I'd like to thank everybody who's listening today, and for those of you that might be listening to this later on in a replay or in some other manner. There's the great information here. First, I want to introduce myself. I'm Joe Valandra. My face and a little bit of my background is on the screen. I'm a member of the Rosebud Sioux Tribe. Currently live and work in Washington, D.C., and I am the Senior Vice President for Tribal Communications. Our mission and our vision is to bring high-speed broadband to all of Indian country. And we have the skills, the background, and the desire, the motivation to take a project from day one all the way to the first day that the network is turned on. With expertise and partners and advice all along the way. But the main reason that we're motivated by this, again, we're a native-owned company. We know the trials and tribulations and difficulties within Indian country from in all 50 states, is to change people's lives. That's sort of been the theme of this presentation so far, and that is continued here. Although we're doing technical things, we're working to provide the actual technology that Medici and other services can be better accessed from. Our goal is to make lives better, to change lives in Indian country, and one of those ways, among several, is through better medical services via high-speed broadband. And that's the context for all of this. Is that without true high-speed broadband, I think Medici can still do many other services, but they can't do them all. We know from experience that the telemedicine that's been provided in some ways through the Indian Health Service has not met expectations, and it often, you still have to go to the IHS hospital or clinic or referred specialist from the IHS with the kind of outcomes that were described by the doctor beforehand. That needs to change for us to have better lives in Indian country. And again, I'll say one of the huge primary motivations for us at Tribal Communications is to give the tools and the technology so that can happen. Now, I'm going to start with some stats that won't shock you, but there's still things that you should be aware of. That the FCC, in one of their most recent reports, which is 2019, they're updating this now, it shows that a little over 95% of the country as a whole has access to broadband services. In Indian country, it's just a little under 80%. Now that doesn't sound too bad, but in reality, when you break it down, only about 50% of tribal households actually have adopted the services, or for any number of reasons. So the true access in Indian country is incredibly low compared to the rest of the population, about half, actually. Another focus study examined both the FCC and examined data from both the FCC and from the Census Bureau, and it shows that home internet in tribal areas is 66% slower than it is in even surrounding communities, that is, communities surrounding Indian land. That 21% difference, which I'm sorry, I skipped over a number. Non-tribal areas have about 87% of the advertised speed for internet. Tribes have 66%. And there's a lot of factors that both bureaus report that add to that. But the main thing is that the service is just not there. And it's the larger gaps in both availability of service and speed are misrepresented to a very large extent. And this is both politics I'm talking about now and just reality, in that there's an overestimation of both the broadband coverage and broadband speeds that the FCC reports generally. And you might ask yourself why that is. Well, the FCC defines their reporting requirements, and the reporting comes from the existing ISP, Internet Service Provider, in the area. But they're defined so that if there's at least one ISP serving a census block, then that census block is considered to be covered. Now, we know in Indian country that that just isn't the case, that the ISP that serves any given Indian community right now may have service, it may be incredibly expensive, or it may be very, very spotty and very slow when there is access. The FCC's current mapping process, current reporting process doesn't adequately address that. So in many ways on the current maps and the maps that are going to be updated, Indian country is going to be misrepresented on those maps. It will show that there is a service provider, that there is service. It will show the speeds and service density that the ISP reports with very little, if any, auditing of those reports. So it's problematic. It's a big issue for Indian country. I really wanted to bring it up here in this context because it is so important, especially as there's expanded funding from the federal government to improve, expand, and otherwise better service in Indian countries from several sources in the federal government. I won't go through those, but all of those fundings, all of the grants and other funding vehicles from the federal government are going to be driven by the FCC maps. I mean, that's something for all of you to know. It's something for all of you to be aware of, to question the reports that you might read, formulate questions for your communities to ask the FCC or the state that you happen to be in. The state also has responsibility in this mapping. So it's a big issue. Now, we all know, and you've just heard a great example from Medici, with high-speed broadband, the impact on healthcare in Indian country can be tremendously positive. In fact, in my humble opinion, it has very, very little way to go except up, but it needs to make exponential changes to have the kind of impact on diagnostics and treatment in the Indian country that we deserve, and that shouldn't be denied us, number one, because we generally live in remote areas, but also because we're dependent on, in many cases, again, on the Indian Health Service. These improved technologies, improved access to healthcare, improved focus on lifestyle that can have generational impacts for our people need to be incorporated into every healthcare plan that a tribe has or that a tribe is working on with IHS now. It's very important. I don't need to emphasize that any more than I already have, but it's very, very important. Now, also speaking of access, one thing that has happened in the last with the infrastructure funding is there were $14 billion was allocated to the FCC to make broadband more affordable. It's called the ACP program, and and I'm going to focus only on tribal lands. Every tribal household that meets the qualifications, which would be most of the households in Indian country, can qualify for a $75 monthly subsidy to help pay for broadband services. That's tremendous. It could make all the difference in the world. In fact, at $75, you should be able to get a true high-speed plan on a monthly plan that really will address all of your needs, both from a healthcare standpoint, education standpoint, business standpoint, and entertainment. The ISPs, you have to apply through the ISPs. I can tell you that Tribal Communications is working very hard to make that access easier. It's not an easy process as it currently is offered, but it's something that those of you listening to the webinar and to everyone else that you speak to in Indian country, they should be looking in and making sure that if they qualify, that they're getting this monthly subsidy to help them both get the broadband, but also sort of relieve some economic pressure that they would otherwise have. I think that's incredibly important. And one more thing about adoption. Within most of the broadband programs, especially those coming from the Department of Commerce through NTAI and a few others, there's money set aside for adoption, which means they'll help buy a laptop computer, a tablet computer, or some other device that can access the internet so that your family, your household can have the access that it doesn't currently have. I think we learned, as you've heard referenced before, from COVID, well, we learned many things from COVID, but we learned that our children can't go to school when there's an event like that. So by having both the high-speed broadband and the device available within your household, education doesn't have to be impacted as much. And now you've learned today that your healthcare can be greatly improved just by having access to high-speed broadband and having the device within your home to make that happen. So I don't have a whole lot more to say, although I could, but I think it's important that in my role in this webinar is to just make you aware that high-speed broadband is coming to Indian country. We're going to do everything we possibly can to make it come to every part of Indian country because of the healthcare benefits that you heard about today and all the others that you know will make your life better. So I'd like to stop now. I'll leave some time for questions, but again, thank you everybody, and thank you the other presenters, excuse me, for being so informative and for helping Indian country. Thank you.
Thank you, Joe. We are now going to move into our Q&A portion of today's webinar. As a reminder, you can ask a question by typing in the chat or question window on your GoToWebinar pane on the right top corner of your screen. Our first question received during the presentation today is directed towards Dr. Allen. Dr. Allen, what percentage of chronic diseases in American adults are mostly due to lifestyle, and why isn't this improving?
Yeah, good question. So, I think it's so multifactorial, but it really depicts a lot of the brokenness of the health system, as well as, honestly, the American culture of who is going to own their health, and I think as I personally did, I outsourced my health. I thought that was someone else's responsibility. So I believe that the people's health is internal as well as surrounded by a team of people that support them in understanding what decisions they make actually drive their health. And so the answer is 80 to 90% of chronic medical disease is directly related to lifestyle choices. So when you look at just addictions, exercise, diet, and sleep, those four things are the main drivers of it. There's two other ones that drive it as well, but those four things alone drive the vast majority of the money we spend in the American healthcare system on things that are completely avoidable with healthy living.
Thank you, Dr. Allen. Our next question. Many Native Americans, especially our elders, have a distrust of technology. Are there any trainings or advice you have to help ease the worries for our members about telehealth?
Well, I'll start with an answer. I think probably all of us could speak to that one a little bit, but yeah, so one of the things we've learned at Medici is don't make things an app if you can avoid it. So make it just really native. If they literally have a phone, they can enter into our system through a simple text-based interface. So one number for the whole tribe. All you have to do is remember that number. And then even if you struggle with getting on a video link, many of our conversations between our doctors and our patients turn into a phone call. Or just texting back and forth. In fact, we think a lot more medicine should be less of a interaction with a formal video or whatever it may be, just to remove the stigma and to speed things up. Text-based or a quick phone call can fix a lot of things. When you can pay providers to actually just do what a patient needs, they change how they interact with patients. We don't have to make you drive to us. We don't have to make you go on a video conference call if that's totally unnecessary. So the answer is we do what's easiest, and most people really could quickly get to the point where they feel like they can text in a number and then interface with our complete healthcare system. And the other thing is we offload most of the work. So at Medici, our navigator really takes on your work traditionally that you do to try and navigate your own healthcare. So we say, once you're in, we will help you get your labs scheduled. We will get your appointments scheduled. We'll make sure you know when all those are. We'll help communicate and keep you up to date on what's going on with the results of those things, and really take a lot of the work away from the patient because we just know that people need help. I know it's frustrating for me to navigate healthcare, let alone for someone that hasn't grown up and spent 30 years in a healthcare system.
Yeah, I'd like to jump in for just a second too. I think that, you know, as I was just speaking about, internet access has been so poor or non-existent, and not only internet access, but even cell phone coverage can be very spotty and unreliable in Indian country. So I think the statistic I mentioned about adoption, you know, being so low that, you know, less than 50% of the households in Indian country, on average, you know, even try to use the internet for anything in particular. That's one factor. There just isn't the experience and the confidence that, number one, that there's access, and number two, that the access will be reliable. And then I also think there's another factor, really, I won't call it culturally, but it has been a way of life in Indian country for a long time, is that Indian Health Service provides healthcare. And that has meant always having to go to either the clinic or the IHS hospital, and then having to wait. Yeah, although that's untenable and it's frustrating and it's inefficient and it's a lot of other adjectives that I won't use here. It's a cultural thing that we're used to going to the doctor, whether that experience was good or bad. We're used to going to the doctor, and I think that, you know, there'll have to be some concerted effort to for people to have confidence in an internet or a phone-based service. But from what Medici describes and what I've seen them do, you know, they build that confidence and that rapport with people very rapidly. In fact, that's their focus, as they say, to make the patient feel, you know, important, loved, cared for. I think that model, along with improved access, much improved access, will go a long way to addressing that concern.
Thank you, Joe and Dr. Allen. Our next question: my rural tribe does not have access to quality internet available in resident homes, only at our local school or clinic. It can be very expensive for residents to access in their home. What are the first steps you recommend to getting access and funding for it?
Well, I guess that's a question for me. I think as I mentioned, there are a number of grant-based programs from the federal government right now with very large dollars meant to address that very concern. Your tribe needs to, if they haven't already, and they may have, they'll begin the application process for those grants, do the planning that's necessary so that the grant, you know, addresses your concern that households have good coverage. But it really starts with the tribe, and there are many pools of money that the tribe can access. And if you have further questions about that, I'm sure you do. I was very general. You know, please drop your email in the comments, and I'll be happy to contact you directly. Thank you.
Thank you, Joe. Our next question: we just started our open enrollment and chose our health plan already for the year. Do I have to wait a full year before I can add a service like Medici to my current employee benefits?
The short answer is no. Medici's offering can be added mid benefit cycle. And how that often works is we work in conjunction with the benefit plan that is in place. Because in some instances, the patient might be in a car accident and Medici can't help them, and we will carefully navigate them to their existing benefit medical plan. So we work with a lot of clients that already have a benefit medical plan in place They then bolt on Medici because it's incredible care for their people mid-cycle. And in the instances where we have to navigate that patient outside of Medici's care to the network that the patient has, we do that on behalf of the patient.
Thank you, Greg. Our next question, how does Medici get patients to engage in their health? One of the hardest parts in our tribal communities is actually getting our patients to comply and engage.
You know, that's a very...
that's the secret sauce, right? So there's good data that relationship with a primary care provider is the biggest driver of patient engagement. So a trusted, loved physician that is going to not give up on some of these things. But what we do is we even tag on to that. So time is relationship in primary care, and there's all kinds of data that says that doctors need more time to build that relationship, and that's why primary care has failed. But we also believe that it shouldn't always be primary care, that it should be no, I want to talk to the nutritionist. I don't want to talk to you. I want to talk to the nutritionist. So make it easy for access to the people that you need help from the most, but everybody on the same team about the lifestyle goals. We're not going to give up on those. We're not going to hurt your feelings. We're not going to step on toes, but we're not going to stop talking about the most important thing that a patient can do to drive their own health. And so being all on the same page, working together on the same record, same communication tools, I think is crucial. And the other thing we do is we provide additional tools for people to use, like that health screening tool, which gives you immediate feedback about your risks for a heart attack, immediate feedback about your risk for a stroke. I think those are powerful levers to get people to start to say, well, I don't feel like I'm going to die of a heart attack, but it says I'm going to 20% chance I'm going to die this year from a heart attack. That sort of information, more continuous information, really starts to develop engagement. And I'll say the third and final thing that really has been proven is that motivational interviewing technique I mentioned, is where you start to really listen to the patient about what is their concern and what would cause them to take the small steps to engage in their own health. That's been proven to be highly effective. Frankly, every doctor should be doing it. Most of them don't dare ask those questions because they're not given the time to do it right.
Kobe, the only other thing that I will add is we have comprehensive campaigns that we work with the tribal leaders on, of how to communicate the benefits of Medici and how it works, ranging from text campaigns to email to whatever is available, posters that might go around in the communities. So we have lots of different avenues and channels that we could explore with the tribe to effectively reach their population. We work in conjunction with them to have the right language, the right tone, the right imagery to make sure that it speaks effectively to their population to help them with engaging with the service.
Yeah, and I'll just throw on top of that is the other thing is sometimes we just have to get you in the door because you haven't experienced healthcare like this, where you're like, man, these guys really care. Wow, they really care about my time too. They make it easy for me to get in. So we'll get you in through a wellness visit, and then you may suddenly say, I want you to be my primary care. We'll get you through a 2 a.m. Am I having a heart attack, or is this I ate some bad chili last night? We'll help you everywhere along the way, but we always point you back to, you need good primary care to really get healthy, and that primary care is going to be who gets people engaged in their health.
Thank you, Dr. Allen and Greg. At this time, we have no further questions for our panelists. I'd like to thank all of our speakers for sharing their expertise on telehealth in Indian communities. And thank you all for participating in our Tribal Edge webinar series, Part 1. Please join us for Part 2 of the series on October 13th, focused on discounted prescription drug costs and better access to medications for Indian country. You can register on the link provided in the copy of the slides you will receive, or online at tribaledgeinsurance.com. That concludes today's webinar. Thank you all for attending.